Okay, we are going to roll right into our knobology. So this is kind of the general term that we give to adjusting all of the controls, all of the settings, everything on our console that we can manipulate while we are scanning. So we know when we're first starting out, one of the most important things, depending on the exam that we're scanning, is going to be the type of transducer that we're using. And the transducer itself is going to be responsible for converting one type of energy into another. So when we're using ultrasound in the clinical sense, we are having this transducer convert electrical energy into acoustic energy. So we're sending electrical energy into the transducer during transmission, and then we're receiving acoustic energy during reception. So we need a piece of equipment, or the literal term transducer, to be able to convert from one type of energy to another and then back and forth again. So we do have different types of transducers depending on the exam that we're looking at, depending on the patient body type. So we can kind of interchange all of these transducers depending on the specific scenario. We know that our transducers are going to be connected to the machine by ports, and these ports are typically interchangeable. So depending on the manufacturer of the machine and the transducers, you can use different ports for different types of transducers. So knobology, like we said, this is going to be the use and function of the ultrasound machine controls. These controls are going to allow us to manipulate and optimize our images in the best way possible. So for us to create high quality pictures during our exams, we have to be comfortable with experimenting with these controls. So different manipulation of controls is going to be different depending on the machine. So on one machine, a certain control may be located in a different area. You may adjust that control differently, but for the most part, that application, that type of control is going to be available on pretty much all clinical machines. So we have to be comfortable with trying new things, experimenting with new things, really kind of see how when you manipulate a specific control, that has an effect on your picture. So we're going to be learning how to manipulate the controls that we have here at the school. And then you have to keep in the back of your mind that when you're starting clinical and you're working at different facilities, different machines are a little bit different from what we have at the school. So for the most part, you're going to have the same type of applications on the machines. They just may be located in different areas, and you may have to adjust them differently. So here's our standard machine. We know that we have a power button, turns it on and off, and we can see our ports located right in the front here. Now, we usually have an open port or a specialized port. So modern machines typically are going to have a minimum of 3 ports, but a lot of machines we're now seeing have a 4th specialized port, and this is going to be used for only specific types of transducers. So maybe the transvaginal probe can only be plugged into that one. Maybe a really high frequency superficial probe can only be plugged into that one. And sometimes that 4th probe is actually, that 4th port is actually inactive. So it kind of just holds that transducer cable, but that's going to be these as well. So you can kind of hang multiple transducers on the machine. Even if there's only 3 ports, you typically have these like stationary ports where you can plug the transducer in, but it's not going to correlate to being active on the screen or being active and ready to use. Okay, so moving through how we would typically scan an exam, we know that we are going to use our touch screen for a lot of our initial setup. So our patient ID or our patient work list is going to be where we can confirm our patient, their full name, spelling, date of birth. Patient ID, like we said, and we know, can be pulled from a system work list or a DICOM work list. We must be properly selecting this for all of our exams. This is a major legal liability, so we have to be scanning our patient under their accurate profile in the machine. So up here we can see our ports that have our transducers plugged in. So we have 3 transducers plugged in, and then we have an open 4th port. We know that our curved probe is active because it's selected and highlighted green. On the side, we're in our patient tab. We can see that this is highlighted. And then we can kind of use this touch screen to do whatever we need to do. Maybe we need to enter in that patient information. Maybe we need more details on that patient. We can find all of that here. So once we are all set with this, we can then move into our transducer selection. So once we have our patient ID confirmed, we're going to move into that transducer. And when we hit our specific transducer at the top, we typically are going to have our presets pop up. So our imaging presets, like we had mentioned in the previous lecture, is going to be something that the manufacturers of our equipment kind of select for us. They basically say these are what we have found to be the optimal settings and starting point for this particular exam. So we use these as a reference point, and it's going to give us standard annotations. It's going to give us standard measurement options. It's going to give us kind of standard grayscale field of view of our picture. So we start from there, and then we can manipulate further as we start scanning our unique patient. So we have our transducer selected and highlighted. We see all of these different tabs popping up underneath it on the touch screen. These are all different folders of presets that are going to be populated with that active curve transducer. So we select the curve transducer, our abdomen folder is going to pop up, but we can also select OB settings, GYN settings, cardiovascular, vascular, urinary, small parts, and pediatric presets in those individual folders. So on the abdomen tab, we can see that we can select from an abdomen, a renal, or an abdomen 2. Abdomen 2 just stands for a patient who might need a little bit extra penetration. They may need a little bit extra sound wave energy because they may have a larger body habitus. So these are standard imaging presets within that abdominal folder. So moving into more of our initial really important controls that we are adjusting very, very frequently, our frequency and our depth. So our frequency is going to be when we're selecting a transducer based on patient anatomy and the type of exam. Now, if we think back to lab, we even kind of go back a slide here. See how the transducer that we have selected says C1-5? C stands for curved. The transducer face is curved, but the 1 through 5 stands for the frequency. So this is saying I am going to be able to produce a frequency range of 1 to 5,000 megahertz, or 1 to 5 megahertz, which is a lower frequency. Lower frequencies are going to be better for us to look deeper into the body. Now, if we go back to this slide as well, and we look at our middle probe, it says ML 6 to 15. So the L stands for linear. It's a flat-faced probe. And then the 6 through 15 stands for the frequency. So 6 to 15 megahertz. So this is going to have a higher frequency than our curved probe. And having a higher frequency is going to be able to help us look at more superficial structures. When you have something that is higher frequency, the sound wave is essentially traveling a little bit faster. But because it's traveling a little bit faster, it loses its overall energy. So think about the Olympics when there's a sprint versus a marathon. Typically, when you're running a sprint, you're running really, really fast. You have these short bursts of energy to complete that race, right? Because you don't really have to run a far distance, but you have to get there quickly. When you're running a marathon, you're kind of pacing yourself, right? You're running a little bit slower, but you are running for longer. So a lower frequency is going to be that marathon. It's traveling a little bit slower, but it's better for us to look deeper into the body because that sound wave is still going to have energy left over to continue traveling. High frequencies, that's the sprint. That's going to be when we're looking at something that's very close to the surface of the transducer, very superficial structures that are located very anteriorly in the body, and we're using a sound wave that's typically traveling a little bit faster in those scenarios. So each transducer, like we saw, is going to have a set range of frequencies that it can be adjusted to. So again, depending on the type of patient or the type of exam that we're scanning with a curved probe, we can adjust the frequency anywhere from 1 with 1 megahertz, which is the lowest megahertz that we can have, and hopefully see the deepest and farthest into the body, up to 5. When we're talking about a high frequency transducer, anywhere from 6 to 15 megahertz can be adjusted. Now our depth, excuse me, I'm like trying to hold in a coughing fit. Our depth is going to be when we are selecting basically the size of our field of view. So how much do we want to see into this patient's body? How deep into the body do we want to see? If our patient is larger, of course, we need to see deeper into the body. So we need to increase our depth. When you're increasing your depth, you are seeing further into the body. When you decrease your depth, you are seeing more shallowly into the body, okay? So it's going to adjust our image and our field of view size. We also can see how deep we are looking into the body because on the side of our screen, there's going to be a little ruler that is present for us to be able to figure out how many centimeters we're evaluating in. So here we have a great example. This is an increased depth. We're seeing deeper into the body here. And this is a decreased depth. We're seeing less into the body, right? Because this is always going to be anterior. This is always going to be posterior. So when we're getting rid of all of that information at the posterior region of our field of view, we are decreasing our depth. Here is what these controls look like on our machine. So we have our frequency button, which is going to be labeled on the touch screen, but we adjust it by the button that's directly underneath it. And anything that's on the touch screen, actually all of our controls kind of have a little cheat sheet for you. So the frequency, it's saying with the button that goes with it, you have to click it either up or down, right? To either increase or decrease that frequency. With our depth, we're going to use a multi-purpose button. So the button that controls our depth is also going to control other applications. So how we adjust that button, how we manipulate that button is going to affect the depth or one of the other controls. So for us, it's telling you, you want to click this button either up or down. If you click this button up, you are going to decrease your depth. If you click the button down, you're going to increase your depth because you're saying, hey, I'm going to click this button down. I'm going to flick it down because I'm saying I want to look in that area. I want to look down, right? So it's almost like you're signaling to the machine, hey, literally keep going down or up, depending on if you want to decrease your depth. And here we can kind of see our nice little ruler on the side of our scanning screen. Gain is another really important control that we are adjusting quite a bit. It's something that we have probably adjusted in lab, but maybe I didn't talk about it too much. Gain is also known as amplification. So it's basically saying to the machine, I either need you to strengthen all of the signals that we're getting, or I need you to weaken all of the signals that we're getting. So it's talking about adjusting the entire image the same way, in a uniform way. I'm either making my image overall brighter or I'm making it overall darker. If I am increasing my gain, I am making it brighter. If I'm decreasing my gain, I'm making it darker. Okay? And as we learn about specific pictures and organs that we have to evaluate, we'll learn about what is an appropriate gain level for specific areas. So this picture here on the side, it's a nice representation of showing what the correct level gain should be on the left side versus when it's a little bit too high, it's a little too bright. So in this picture, I would decrease my gain to make my overall picture darker so that it looks something like this. Now, in order to manipulate our gain, we're going to use the button that has a B on it, and we just turn it like a knob. So you turn it to increase it, and you turn it the opposite way to decrease it. Next, we have something that's a little bit similar in concept to gain, but a little bit more precise. So we have our time gain compensation, also known as TGC, and we have our representative TGC curve. So TGC is talking about adjusting the amplification of the signals on a horizontal level. So as our sound wave travels into the body, right, this is always anterior, this is always where our sound source is coming from. Our sound wave is always coming from here and traveling deeper into the body, into the posterior region. So as those sound waves travel to deeper depths and different levels of the body, when we get reflections from those levels, they have different strengths. So we're always going to kind of get stronger signals coming from the more superficial region than we are the deep region. And that's just because those sound waves have to travel longer, right? They kind of lose steam by the time they get back to us after they've been coming from a really deep level. So we typically see pictures get darker as they travel deeper into the body. So we have to account for that. We want to make sure that our picture is nice and uniform. And yes, we can use gain to help. Guys, there's literally somebody standing on the roof right outside my window doing construction. So I apologize. And I'm a little bit distracted, but we're going to do our best here. So we want to have a nice uniform picture, and yes, gain can help us do that, but gain is only going to adjust the strength of the picture overall. Sometimes I only need to adjust the bottom of my picture, or I only need to adjust the top of my picture, and that's what TGC is going to allow us to do. So if we look at our TGC curve, it's going to be this little kind of collection of these tiny little knobs that we can move side to side. If I am adjusting, so kind of the buttons in the middle here are always going to kind of adjust the mid portion of our picture. The buttons on top are going to adjust the top part, and the buttons on bottom are going to adjust the posterior part of our picture. Now, if we look at that curve, all of those buttons are all aligned with each other, right? So we're not implementing any sort of TGC with this picture. Now, if we look at the picture to the right, if we look at picture C, well, the top controls are moved to the left. The middle controls are kind of still in the middle, and the bottom controls are all the way to the right. So when we move anything in our TGC curve to the left, we're making it darker. When we move any of the controls to the right, we're making it brighter. So if you look at this picture that's representing this curve, the top part of our picture is dark and the bottom part of our picture is brighter. Okay, so if we use that same concept and now we look at the picture to the left, picture A, we still have a curve for our TGC curve, but our knobs on the top part, our anterior knobs, are moving to the right, and our posterior knobs are moving to the left. So we're making the posterior part of our picture darker, and we're making the anterior part of our picture brighter. And you can see that here. Brighter anterior, darker posterior. So it's each of these little knobs is going to adjust that specific level range of brightness depending on which way you move it. We also can evaluate the severity of our TGC curve on our picture. There's usually going to be some kind of vertical representation, which these pictures don't currently have. But if I were to draw my screen like this, we sometimes will see when we're using TGC a curve that looks like that. There'll be some kind of like curved line or some kind of like that. Depending on how we're adjusting the TGC, we'll see it on the side of our picture. Okay, so continuing on here with some of our major controls, next is going to be our focus. This is very important. This is something that when we're adjusting our depth, can you guys hear this? This is crazy. I am so distracted. I apologize. When we adjust our depth, we have to make sure we're also adjusting our focus. So our focus is basically saying, I want the strongest part of my sound wave to be at this level depth in the body. So it's saying, okay, I want to concentrate my energy to this point. I want to draw attention to this level of my picture. When you adjust your focus, you're not changing your depth. Remember, depth is something different. But focus is saying, okay, I want this to be the level of anatomy that I'm really trying to showcase here. We typically try to scan with only one focus, right? Because if we think about that, think about your attention span. When you're only focused on one thing at a time, you do a better job at that one thing. But on our machines, we can add multifocal zones. So we can have a multiple focus exam. And there are going to be some detriments to that. So it's going to slow down our picture. It's going to make our detail of the picture, our resolution, not as great. So we try to only scan with one focus at a time, but there are certain times where we can use two, depending on what we're looking at. So remember, if you are increasing or decreasing your depth, it's typically because you either need to see more or less, right? So if you look at this picture here on the left on the bottom, this is the picture of that right lobe of the liver. We should remember that from lab. When we're looking at the right lobe, we want to make sure we're seeing all of the borders. So here is that posterior border of the liver. And I want to make sure that I have my depth set to an appropriate level. I don't want to have my field of view coming all the way down here because I don't need any of this information, right? So I have my depth at an appropriate level. And then my focus is saying, okay, I'm trying to show you that posterior border. I'm trying to bring your attention to this and send the most amount of strong energy to this level of that posterior border. So I'm going to set my focus right here, right at the level of where that posterior border is. Okay. So up here, this is just another example of using two focal zones. So here is one focus and here's two. And the reason that we're using two for this one is because I am trying to draw attention to this border of the thyroid, but I'm also trying to draw attention to this lesion that I see in the thyroid. So I'm trying to draw attention to two different levels of my picture. So I'm using two different foci for multiple. Now, how do we adjust that? Similar to our frequency, we're going to see it represented on our touch screen, but we're going to be adjusting it with the knob on the control panel right underneath it. This button is also a multi-purpose button because we can either increase or decrease the number of focal zones we're using, and we can adjust the position that we have our focus set at. So if we turn this knob, we're going to increase or decrease the number of focal zones. Or if we click it up, we will put our focus at a higher depth, right? So our focus would be up in this region. And then if we click this button down, we would move our focus down to a deeper level. Next, we have our dual image screen and our right and left image display. So our dual screen is something that we use all the time. We're going to start to be using this, especially in the spring semester. It's when we're able to use two images or two display images in a side-by-side fashion. So we use this when we're comparing things. Now we learned that when we're measuring something that doesn't belong, we always have to evaluate it in two planes, and we use dual screen to show those two planes. So it's very helpful for comparison. It's very helpful for measurements. It's just an all-around great tool that we're going to start to be using more of. Our right and left image direction, this is when we can actually reverse our display screen. So we can either have our image be flipped up and down or side to side. We don't really ever use this, but you need to be aware of where it is and what it does, because sometimes you'll be scanning and you're like, wait a minute, why is my little indicator on the top right side of my screen? It should always be on the top left side of my screen. So if you see that, you know that you somehow clicked the image reverse button on the right and left image display, and now you're like, okay, now I know how to put it back to the true way. So this is a great picture of a dual screen. And then here's how we would adjust both of those. So with our dual, we're using these two side by side, left and right. This is just saying that when I click the left button, I want to be scanning on the dual screen that's located on the left side. Or if I click the right button, it's going to update me to move over to the screen on the right hand side. So if here's a display screen on the left, and here's a display screen on the right, if I hit that button with the L on it, I'm going to be active on this side. If I hit that button with the R on it, it's going to move from the left and now be active on the right side. In order to activate dual screen, all you have to do is hit either or. Now, image reverse is going to be this backwards R, so we're back to that multi-purpose button that we used for depth. It's telling you that if you push this button down, you're going to reverse your image. And again, not something that we use, not something that we want to use. There's really no need for us to use it. But if you notice that your image is flipped and you're like, why does my picture look so weird? I'm like, it looks like I'm scanning in the opposite direction. It's probably because you accidentally pushed down on that button and caused the picture to flip. Moving on, our pretty important pictures in terms of image obtaining images. We have our freeze button. We should know where that is by now. It is when we can suspend our real-time scanning. It freezes our picture for us. When it's frozen, it actually kind of temporarily stores the last few seconds of your scanning. So when you're frozen, yes, you can use that as a way to look at your picture before you save it, but you can also use that as a way to kind of back scroll from things that you had seen 1 to 2 seconds prior to when you froze the picture. And that's going to be done through our cine loop. So that's when we use our trackball. So once our image is frozen, we can scroll back, we can cine loop back using our trackball to kind of see those last few frames that our machine was storing right before we hit the freeze button. So this is a great way for us to kind of review an area that we're maybe not so sure of, or maybe if there's motion with our patient, maybe they couldn't hold their breath. Maybe we had to use our left hand for something else while we were scanning in terms of like helping the patient or holding the patient. We can freeze and know that we can go back a few seconds and we would still probably be able to take that picture that we saw nicely for a very quick period of time. And then in order for us to save either an image or a cine loop, all we have to do is hit our print key. If you happen to hit the print key without freezing, that is how you take a cine loop. That is how you save a cine loop. So the last few frames prior to you hitting the print button are going to be stored as an image clip, not as a still image. When you hit freeze and then print, that's how we save one still frame. Here is where they're located. So here's our freeze button, pretty obvious. It's a nice big button, easy for us to access. And then on our machines, anything with P1 or P2 are going to be our print buttons. We typically use P1. You'll see a lot of different printing options on the machines at Clinical. Some of them go to an actual image printer. So some places will use like maybe P3 as a way to print, those cute little ultrasound pictures that we see OB patients getting. But we don't have any of those active here at the school. So we're usually only using P1 and then sometimes P2. And then our trackball, like we said, we can use that to help us scroll back through a cine loop, but we can also use it for an array of different things, whether while we're scanning, after we're scanning, or before we're scanning. So our trackball is going to kind of be like our computer mouse. It's going to guide the cursor on our screen. It's going to help us to be able to set measurements when we're trying to measure an organ. We can change the scanning area when we're using certain applications. We can use it to scroll back on a cine loop, like we said. So a very multifaceted application with that trackball right in the middle. Picture on the left hand, star on the left hand side of the trackball is going to be our set, so kind of like the little clicker on your mouse of a computer. This could vary from machine to machine, and the way for you to tell which of these buttons would be your set is on the screen. We have our little GPS system on the bottom right hand corner, And that's always going to kind of tell you like what the controls do above the trackball, to the side of the trackball, below the trackball, and on the other side of the trackball. So if you're ever not sure what these 4 buttons do, look at your little GPS on the bottom right-hand side of your actual imaging screen. It will tell you, because sometimes the purpose of these buttons will change depending on what we're doing. Next, we have our zoom and our sector width. So if we want to magnify a certain area of our picture, we're going to use our zoom control. And then our sector width is also going to be able to allow us to kind of narrow in the field of view. So just like our depth increases or decreases the distance of our field of view, our sector width is going to increase or decrease the width of our picture. So this one, we have a wider sector width, and this one, we have a narrow sector width. We always want to be able to use a narrow sector width because it helps us to improve our frame rate, so the speed that we can scan with. And then the detail or the image resolution also improves when we have a more narrow sector width. So as we start learning about specific organs, once we get to gallbladder, once we get to kidney, we'll start using a narrow sector width with some of those pictures, and you'll be able to see how that affects our image. Same thing with zoom. Once we start learning about some of the small structures in the liver and the biliary tree, we'll be zooming in on certain areas. So here's our zoom button, top right from our trackball. All you're going to do is push that button in. And then our sector width, back to that button with our depth. If we turn this knob one way, it will increase or decrease our sector width. One way, it will increase or decrease our sector width. So it's literally, I just drew right over it, but it was literally just telling us what we have to do right here. So pretty helpful if you look at the fine details. And then kind of getting towards the end of some of our major controls here, we have annotation and calipers. So annotation is just a fancy word for labeling our picture. We have 2 different options typically. Usually you can type your annotations with the keyboard like you can see here, or if you hit the comment button on your touch screen, you're going to get a pre-populated list of common labels that you can use depending on the preset that you selected at the beginning of the exam. So if you selected the abdominal preset, you're going to get all of these options that you can just very easily tap, and they'll pop up on your screen so you don't actually have to type them out. You'll have pancreas, liver, gallbladder, all those common annotations that we would use for that specific preset will be under that category. Calipers, this is how we measure something. So we can use kind of pre-populated calipers. You'll see some text using that where the machine kind of guesstimates what a measurement is going to be, but everybody should be in the habit of manually calipering, manually measuring anything that we see. So organ size, any pathology, we're using our calipers to do so. In order to get our calipers to pop up, we hit this measure button right above our trackball, and we're going to get a little caliper that pops up. We use our trackball and our set button to put that caliper where we want. So say we're looking at the kidney, and here's my kidney. I'm going to get my caliper that pops up. I want to put it on one end of my kidney. I'm going to hit set, and then I'm going to go, once I hit set, it's going to bring another one that pops up, and I'm going to put it on the other end of the kidney and hit set, and then it'll save that measurement. Okay, so moving into a little bit more advanced controls that we will get to in lab and we will get to by the end of the semester, but these are controls that we're going to learn a lot more about when we start physics in the spring. We have color Doppler, color power Doppler, and pulse wave Doppler. The purpose of all of these is to look for vascularity, to look for blood flow. So color Doppler is going to be kind of our first stop. It's going to basically say, is there blood flow in this specific area or is there not? Now, color Doppler uses bidirectional representation. So it says, yep, I'm picking up blood flow, and it's either traveling to the transducer or away from the transducer. Now, if we're struggling to find blood flow in a structure, there's a more sensitive version that we can use to pick up on really tiny blood vessels, or maybe blood vessels that are moving too slow for our standard color Doppler to pick up. That's going to be our color power Doppler. Now, the problem with color power Doppler is that it's not going to be able to display a direction for us. It just tells us, is there flow here or not? The other issue with color power Doppler is that sometimes it's so sensitive that it picks up motion from other structures. So it picks up motion from breathing, or it picks up motion from literally the patient moving. And now it's no longer picking up motion from the blood vessels. It's picking up fake motion from the patient breathing or the patient moving. So sometimes color power Doppler can give us a false vascularity for a structure that maybe doesn't really have vascularity. Now, if we want to take that blood flow a step further, we can add pulsed wave Doppler. Now, this is something that we usually only add to color Doppler. We don't really rely on pulsed wave Doppler if we're having to use color power Doppler. So pulsed wave Doppler, what it's going to do is it's going to give us a second application on top of the color representation and direction of blood flow from color Doppler. We're going to be able to actually measure the velocity and the blood flow waveform patterns. So let's take a look at what that looks like. So here we have our color Doppler. We're seeing directional flow of blood vessels right here. This is our little map that we use. Anything above the midline is going to be flow towards our transducer, and anything below the midline is going to be flow away from our transducer. So in this case, the vessel that is popping up blue is traveling away from our transducer, and the vessel that's popping up red is traveling towards our transducer. Now here at the bottom, we have that color power Doppler. It's picking up very small vessels in the kidney, but we're only seeing one color. And that's because we're not going to get directional flow. It's literally just saying, hey, there's motion in this area that we can assume is vascular motion. But you have to keep in the back of your mind that sometimes that motion can be fake. And then here we have our pulse wave Doppler. So we're using our color Doppler application initially on our picture. And then when we hit pulse wave Doppler, we're going to get the scan line that pops up right here. We want to place our little addition sign right in the middle of our vessel. Once we hit update, we're going to get this beautiful waveform that's going to represent all of that blood flow in that specific area that we put that little addition sign in. From here, we're able to measure things. We're able to evaluate the behavior of the vessel in that area. So a lot of helpful information comes from pulse wave Doppler. And here we piece together all of the controls. So you can use this as kind of a study guide for our machine in lab. But remember, when you start clinical, some of these controls are located in different areas. Some of the multi-purpose controls are encompassing of different applications. So this is not the end-all be-all in terms of Knobology placement. This is just what we have at the school. So this can help you prepare for lab a little bit better. Now, in terms of controls that we don't use, but I'm required to teach you, these are all things that will come back when we learn physics in the spring. But we do have compression and rejection. I honestly couldn't even tell you where these controls are located on our machines because we quite literally never use them. You may see some old school techs using and adjusting these out in clinic, but it's not standard practice. So compression, all it is just going to change our grayscale by reducing the range of our signals. So sometimes we get a wide variety of signals that return to our transducer. So it's basically going to say, okay, I don't really need this like abnormally high signal and I don't really need this abnormally low signal. So I'm kind of just taking the average signal to calculate a grayscale of the picture. Rejection is going to be when we kind of get rid of the signals that are really not clinically relevant. So they're really like so weak and so low that the machine kind of just doesn't even process them. So this is also known as suppression and threshold. This is really just going to kind of get rid of like the really dark echoes on our image, and the bright echoes, the bright areas are not going to be affected if we were to use rejection. Now you have to be aware of what we call post-processing. We try to manipulate all of these controls while we are live time scanning. That's the best practice possible. But there's some times where maybe you have to just freeze the picture, you have to just get what you can get, and then you can post-process some controls. Not all of them. So there are certain controls that are not ever going to be eligible for doing after the point of having already froze or printed your picture. You cannot adjust your depth, your frequency, your focus, or any Doppler application while you are not live scanning. You have to be live scanning to adjust those controls. Sometimes, if you're frozen or if you've actually even already taken the picture and you pull the picture back up, you can change your annotations. Sometimes you can move your calipers. Sometimes you can adjust your gain, and sometimes you can adjust your TGC. Now, with only really modern machines are you able to adjust your zoom and your sector width once you're frozen or have already printed that picture. Again, this is not something that I want you guys to practice, but you need to be aware that there are certain things that you can change if you've already frozen or taken that image. But we are going to practice good habits of using pre-processing. So let's go through some examples here of what we should do through these pictures. So the anterior region of our picture is way too dark. What controls should we be manipulating to adjust this? So take a second, you can even pause me here, try to get the answer, and then you can come back. So the answer to this one is going to be to adjust the anterior controls of our TGC curve and move them to the right. So our anterior field of view is too dark. My posterior field of view is nice. I don't want to adjust that. I don't want to change that at all. I just want to change the anterior part. So when I have my TGC controls, right, here's going to be my standard. Imagine these are all straight lines. I want to move these controls to the right to get them to brighten up so that it's a uniform brightness of my posterior field of view. Next example, you're having difficulty visualizing deep structures within the body. Your depth is set correctly, but you need to improve your penetration. What control can you manipulate to adjust this? So again, take another second. You can pause me, try to get the answer for yourself. With this one, what you want to do is you want to adjust your frequency. So within the range of your transducer, you want to be decreasing your frequency to be able to increase the penetration. So remember, lower frequencies, a decreased frequency is going to have better penetration. It's going to be able to travel further. That's the marathon. Remember, you're going to be able to run for a longer distance because you're traveling more slowly. You're decreasing your frequency. And our next one, the entirety of your image is too bright. What control can you manipulate to adjust this? Same thing, pause. With this one, you want to adjust your gain. So your overall image is way too bright. You want to decrease your gain. You want to make that overall image darker. And lastly, you found a kidney stone that you want to magnify. What control can you manipulate to adjust this? With this one, you want to be able to zoom in on that area. So if we are asking to magnify something, we are going to zoom in on it to get a bigger evaluation of that area. So, some of these concepts, like we've gone over in lab already, some of them are a little bit more straightforward than others, but please make sure you have a good understanding of these controls. I don't expect you guys to be able to pinpoint them precisely on the control panel as soon as you come into lab, but I do expect you guys to have a pretty good foundation of knowledge when it comes to how you can manipulate your picture when we're in lab. So I don't expect you to know how to do it hand-eye coordination right away. You'll learn where those buttons are over time, but I want you to be able to know if I ask you a specific question about how to make your picture better, you'll know what control to use in that scenario. So any questions, as always, please do not hesitate